Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important part of the vasculitis, that is the Takayasu arteritis. So Takayasu arteritis, it is a large vessel vasculitis, right? And another important example of the large vessel vasculitis is the giant cell arteritis, which is also called as temporal arteritis. And in Takayasu arteritis, you should know what is the main vessel that is being affected. So Takayasu arteritis mainly affects pulmonary artery, celiac artery, subclavian artery, superior mesenteric artery. So the answer to this question is the subclavian artery is the one which is most commonly affected or mainly affected in these patients with the Takayasu arteritis. And subclavian artery, if you see that on the left side, right, left subclavian artery, it directly originates from the arch of aorta, whereas if you see the right subclavian artery, it is a branch from the brachiocephalic trunk. Right, it is a branch from the brachiocephalic trunk. So that is about your right subclavian artery. So it is the subclavian artery which is commonly affected. And you have to understand that this subclavian artery is the one which will continue as the axillary artery into the upper limb. And this axillary artery further continues as the brachial artery. And brachial artery, right, will further continue or which will divide into the ulnar artery and as well as the radial artery. Right, it will divide into the ulnar artery and as well as the radial artery. So that is about the continuation of the subclavian artery, and the main vessel which is affected is the subclavian artery. Now, what is the major difference between your giant cell arteritis and as well as the Takayasu arteritis? So I have said you that both of these are large vessel vasculitis. The very important point of difference is the age. So if you see the giant cell arteritis, it occurs in age group of more than 50 years, whereas in case of Takayasu arteritis, it occurs in age group less than 50 years, right? Usually around 40 years of age, right? Usually around 40 years of age, you will have the Takayasu disease or the Takayasu arteritis. And what is another name of the Takayasu arteritis? So please remember the another name of the Takayasu arteritis, it is called as aortoarteritis. Right? So now the question is, why is it called as aortoarteritis? Because the main vessel or the most common vessel which is affected is the subclavian artery. And this subclavian artery is the one which originates from the arch of aorta, right? Subclavian artery is the one which originates from the arch of aorta. Now, because the subclavian artery is the one which is originating from the arch of aorta, that is the reason why this is called as aortoarteritis, right? That is the reason why this is called as aortoarteritis. So, if you observe here, this is the left subclavian artery which is originating from the arch of aorta, and this is the right subclavian artery which is originating from the brachiocephalic trunk, right, which is originating from the brachiocephalic trunk. So these are the vessels which gets affected in patients with Takayasu arteritis. This is the main vessel. Many other vessels are affected, but this is the main vessel. Now we have another name for this particular Takayasu arteritis. So another name for Takayasu arteritis is that it is also called as pulseless disease. Right, this is also called as pulseless disease. So why is that? Because you see the subclavian artery, it continues as the axillary artery. Axillary artery, it continues as the brachial artery, and brachial artery, it divides into two branches, right? That is your ulnar artery and as well as the radial artery. Now, once this vessel is inflamed, once the subclavian artery is inflamed, what will happen to the blood supply in the continuation? The blood supply or the blood flow in the axillary and as well as in the brachial artery also will be reduced. So thereby what will happen to the perfusion in the radial artery, or what will happen to the blood flow within the radial artery? Blood flow in the radial artery is also reduced, and sometimes if the severity is more, the pulse is not being felt at all, and that is what is called as, that is the reason why it is called as the pulseless disease, right? Now, if you observe the clinical features of the Takayasu arteritis, so in all the forms of vasculitis, please remember you have the presence of the constitutional symptoms, and that constitutional symptoms are mainly because of the inflammatory component, and that particular constitutional symptoms include the development of fever, then weight loss, then followed by that fatigue. So these are the non-specific features of the vasculitis: fatigue, weight loss, and as well as the fever. Now, followed by that, you should know what are the vascular symptoms. See, vascular symptoms in these patients with the Takayasu arteritis, it is mainly because of the narrowing of the affected vessels, right? It is mainly because of narrowing of the affected vessels. Alright, so what will be the features because of the narrowing? The pulse is completely absent, right? There is weakening of the pulse, and due to which it is called as the pulseless disease. And even if you observe the blood pressure, there will be reduced blood pressure in the upper limb in which side the subclavian artery is affected. For example, if the inflammation is present only on the left subclavian artery, then the blood pressure of the left upper limb will be less than compared to that of the blood pressure of the right upper limb. So that will result in what is called as unequal blood pressure between the right and as well as the left arm is being seen. But there are many other conditions where you have unequal blood pressure between the right and as well as the left arm. Now let me tell you the examples, right? One is your Takayasu arteritis. Right, one is your Takayasu arteritis. The other one is coarctation of aorta. Right, the other example is the coarctation of aorta. Right, and that too, let me tell you, coarctation of aorta, if you see, the most common site. Right, let me just draw this particular coarctation of aorta. So consider this is the four-chambered heart. Then we have the aorta originating from the left ventricle, and this will be your brachiocephalic trunk, this will be your common carotid artery, and this will be your left subclavian artery. Most common site for the coarctation will be distal to the left subclavian artery. That is the most common site for coarctation. But if the coarctation is present distal to the left subclavian artery, you don't have difference in the blood pressure between right and as well as the left arm. But for suppose, if the coarctation is present proximal to the left subclavian artery, right? If the coarctation is present proximal to the left subclavian artery, then in this case you have the difference between the blood pressure of the upper limb and as well as you have the difference in the blood pressure between the right and as well as the left arm. Okay, so that is what you will observe in the coarctation of aorta. So in coarctation of aorta, that too preductal coarctation of aorta, you have unequal blood pressure between the right and as well as the left arm. And other condition where you have unequal blood pressure between the right and as well as the left arm is obstructive aortoarteritis. Right, obstructive aortoarteritis, and then supravalvular aortic stenosis. Right, supravalvular aortic stenosis, then followed by that aortic dissection. Right, aortic dissection. So these are all the conditions where you have unequal blood pressure between the right and as well as the left arm. In a normal individual also, there can be minimal difference in the blood pressure between the right and as well as the left arm. So how much is that minimal difference in the blood pressure between the right and as well as left arm? up to less than 5 millimeters of mercury, right, up to less than 5 millimeters of mercury is acceptable between the right hand as well as left arm. That can be seen even within the normal individual also. But in these scenarios, the blood pressure difference between the right hand as well as the left arm will be more than 5 millimeters of mercury, right? So this is a very important multiple choice question that you have to remember. Now, let me discuss the clinical features in patients with the Takayasu arteritis. So I have said you the main vessel that is affected in patients with Takayasu arteritis is subclavian artery, and it is the one which is supplying to your upper limbs. So what will be the clinical presentation in these individuals? Because there is decreased blood supply to your upper limbs. So what happens is when the individual starts working with the upper limbs, right, or when the individual does excessive work with the upper limbs, the blood supply to the upper limb gets compromised. So there will be development of pain within the upper limbs, and that will result in what is called arm claudication. Right, that will result in what is called arm claudication. Okay, right, that is the important symptom. What do you mean by the word claudication pain? The pain increases on doing any particular work within the arm, but once the individual take rest, the pain will get reduced. That is what is nothing but your claudication pain. Okay, and another important feature is that there will be unequal blood pressure between right and as well as the left arm. Right, unequal blood pressure between the right and as well as the left arm. Okay, next, the other important point is that the clinical features completely depends upon the vessels which are being affected. Now let me take up the discussion accordingly. See, most common vessel which is being affected here is the subclavian artery, right, and when there is involvement of subclavian artery, we have discussed that the individual will have the claudication pain, right, or even there can be development of the Raynaud's phenomenon. The other vessel which gets affected is the common carotid artery. See, common carotid artery is the one which will give branches to the cerebral circulation. It is the one which will divide into external and as well as internal carotid, and internal carotid is the one which will give rise to your anterior and as well as the middle cerebral artery. So if you take the branches of common carotid artery, right, it divides into external carotid artery and then internal carotid artery. And internal carotid artery, the terminal branches, if you see, anterior cerebral artery and as well as the middle cerebral artery. So your common carotid artery is giving anterior circulation to the brain, and if there is inflammation in the common carotid artery, what will happen? The perfusion to the brain will be reduced, and that can result in the syncopal attack, right, and there can be development of transient ischemic attack, right, and there can be development of ischemic strokes as well, right, there can be development of the ischemic stroke as well. So these are the features due to involvement of the common carotid artery. And the continuation of the descending aorta will be the abdominal aorta. Even abdominal aorta can get affected in Takayasu, and abdominal aorta is the one, the branches which are originating from abdominal aorta will be supplying to the visceral organs. So once the abdominal aorta gets affected, the blood supply to the visceral organs within the abdomen will be reduced, and the individual will have abdominal pain. Right, the individual will have the development of the abdominal pain. Next, coming to the renal artery. So renal artery is the branch which is originating from the abdominal aorta, and if there is involvement of the renal artery, what will be the manifestations? So there will be renal artery stenosis, right, there will be narrowing of the renal artery, and because of which there will be decrease in the glomerular filtration rate. So once your glomerular filtration rate is reduced, immediately there will be release of renin. Right, once the GFR is reduced, your GGE apparatus, right, juxtaglomerular apparatus detects the decrease in GFR, and your JG cells, they will release this particular renin, and this renin, it will cause the activation of renin-angiotensin-aldosterone system. Right, this particular renin will activate the renin-angiotensin-aldosterone system. So once this renin-angiotensin-aldosterone system is activated, there will be release of angiotensin 2. Right, there will be release of the angiotensin 2 and there will be also release of the aldosterone. Right, there will be also release of the aldosterone. So this angiotensin 2 and aldosterone will increase the blood pressure of the individual, and that we call it as renovascular hypertension. Right, that we call it as renovascular hypertension. Right, so that is about the clinical manifestation because of the involvement of the renal artery. And the treatment what you can give for, suppose if it is like unilateral renal artery stenosis, you can give AC inhibitors, right, or you can also give angiotensin receptor blockers. But a very important point you should remember is that if suppose if there is bilateral renal artery stenosis, then in such case AC inhibitors are contraindicated. Right, the AC inhibitors are contraindicated if it is like bilateral renal artery stenosis. Then how is that you will treat if there is bilateral renal artery stenosis? You have to do what is called PTRA. Right, you have to do PTRA, that is percutaneous transluminal renal angioplasty. So PTRA has to be done, right, wherein you need to keep a stent within the renal artery and you need to open that particular stent, and wherein the stenosed renal artery will get opened. Okay, right. So that is about your treatment of bilateral renal artery stenosis. And at the same point, let me just explain you what are the other causes of renal artery stenosis. In elderly individuals of age group around 60 years, the cause for the renal artery stenosis will be atherosclerosis. Right, the cause for the renal artery stenosis will be atherosclerosis, and the other causes for renal artery stenosis will be fibromuscular dysplasia. Right, fibromuscular dysplasia. So these all will be the features that you will see in patients with the Takayasu arteritis due to renal artery involvement. Then after having discussed about the involvement of the renal artery, the next important is the vertebral artery. See, vertebral artery, it is a branch of the subclavian artery, and the two vertebral arteries, they will unite to form the basilar artery. Right, the two vertebral arteries, they will unite to form the basilar artery. And this particular basilar artery, it will give the posterior circulation. Right, it will give rise to posterior circulation to the brain. Now this posterior circulation to the brain, if it gets affected, then what will be the clinical manifestations? So the individual can present with dizziness. Right, the individual can present with dizziness because the blood supply to the cerebellum and the blood supply to the brainstem, it gets affected, and there can be also visual changes that will appear. Right, there can be also development of the visual changes as well. So this will be the features due to the involvement of the vertebral artery. Next, coming to the involvement of the celiac axis. See, celiac axis or the celiac artery is a branch which is originating from the abdominal aorta, and it is the one it will supply to the foregut. So when the blood supply to the foregut is reduced, the individual will have the clinical features like nausea, then vomiting, and there will be also development of abdominal pain. Right, there will be also development of the abdominal pain. So these are the features due to the involvement of the celiac artery. Then followed by that, the iliac artery. See, the descending aorta continues as abdominal aorta, and abdominal aorta terminal branches will be the iliac arteries. Right, we have two common iliac arteries, right and as well as left common iliac arteries, and these iliac arteries will divide into external iliac and as well as the internal iliac. So the iliac arteries are the one which will supply to the lower limbs. So what will happen to the blood supply once there is involvement of the iliac arteries? The blood supply to the lower limbs will be reduced. So that is the reason why the individual will complain of leg claudication. Right, the individual will complain of leg claudication. It is same. On walking, the individual will have very severe pain, and once the individual stops, the pain will get reduced, and that is what is called as the leg claudication. And other vessel which gets affected is the pulmonary artery. So what will be the clinical manifestations due to the involvement of the pulmonary artery? The individual can have the development of dyspnea, and there can be atypical chest pain. Right, there can be development of atypical chest pain. So that is due to pulmonary artery involvement. Next, followed by that, due to the involvement of the coronary artery, the individual will have the development of myocardial infarction, right, and because of which the patient will present with chest pain. Right, because of which the patient will present with chest pain. So this will be the manifestation due to the involvement of the coronary artery, right. So you see the question, Takayasu arteritis mainly affects the subclavian artery, and this will be the summary of the clinical features in patients with the Takayasu arteritis due to the involvement of the various vessels, right. Now I've said you that there will be ocular disturbances in patients with the Takayasu arteritis, and this ocular disturbances, let me tell you, that is mainly because of the involvement of the ophthalmic artery. And this particular ophthalmic artery will be the branch of the internal carotid artery. And what will be the visual disturbances? That includes retinal hemorrhages, right, that includes retinal hemorrhages, and there can be even development of total blindness. Right, there can be even development of total blindness. So this will be the ocular disturbances that you can have in patients with the Takayasu arteritis. Next, Takayasu arteritis, just now I was discussing that it can also cause myocardial infarction. And why is this particular myocardial infarction? Let me tell you. Which part of the coronary artery gets affected in Takayasu arteritis? It is ostia of the coronary artery. So it is due to, right, it is due to narrowing of, right, it is due to narrowing of the ostial part of coronary artery. Right, it is due to involvement of the ostial component. Right, for example, this will be your ascending aorta, and from the ascending aorta you have the right and as well as the left right and left coronary artery. And what is that particular ostia I am talking about? The origin. This will be your ostia. There will be ostial narrowing, and because of which the blood supply to the myocardium will be reduced, and that will result in the development of myocardial infarction. Right, and hypertension is seen in almost 50% of cases, and that is due to narrowing of renal artery, and that we call it as the renal artery stenosis. Now there is one important question that you have to know. Reversed coarctation of aorta is seen in giant cell arteritis, polyarteritis nodosa, Takayasu arteritis, and as well as the Kawasaki disease. So the answer in this question is the Takayasu arteritis. Reversed coarctation of aorta is seen in the Takayasu arteritis. Now what do you understand by this word, the reversed coarctation of aorta? Let me explain you. So if you see this is the ascending aorta, right? This will be the arch of aorta. Then we have descending aorta, and this will be your left subclavian artery. Right, this will be your left subclavian artery. So In case of coarctation of aorta, the common site for coarctation is distal to left subclavian artery. Right, distal to the left subclavian artery, you have the narrowing. Right, now the point is, when there is narrowing distal to the left subclavian artery, what will happen to perfusion to the lower limb? Perfusion to the lower limb will be reduced. Right, perfusion to the lower limb will be reduced. So once the perfusion to the lower limb is reduced, what will happen? The blood pressure in lower limbs will be reduced. Okay, so in case of coarctation of aorta, upper limb blood pressure will be more than compared to that of the lower limb blood pressure. That is what will happen in coarctation of aorta. Right, that is what will happen in coarctation of aorta. But in case of Takayasu, what will happen? In case of Takayasu, you see here, it is the subclavian artery which is being narrowed. Right, the subclavian artery, it is being inflamed. So when subclavian artery is being inflamed, what will happen? The blood supply to the upper limb will be less. Right, the blood supply to the upper limb will be less then compared to that of the blood supply to the lower limb. So in this case, what will happen? You see, the blood pressure in the lower limb will be more. Right, the blood pressure in the lower limb, it is more then compared to that of the blood pressure in the upper limb. Right, blood pressure in the lower limb is more then compared to that of the blood pressure in the upper limb. So you observe here, in coarctation of aorta, the upper limb blood pressure will be more than compared to that of the lower limb blood pressure. Whereas in Takayasu arteritis, it is exactly reverse. The lower limb blood pressure will be more compared to that of the upper limb blood pressure. That is the reason why we call it as reversed coarctation of aorta in patients with the Takayasu arteritis. So you just see this particular flow chart. In coarctation of aorta, there is an obstruction distal to the location of the subclavian artery. So thereby, there will be normal blood flow in the upper extremities and reduced blood flow in the lower extremities. And there is absence or diminished pulse in the lower extremities. So that is the reason why there will be increased blood pressure in the upper limbs, where in coarctation of aorta. You take in case of the Takayasu arteritis. In Takayasu, the obstruction involves the proximal part of the aorta that is exactly at the origin of the subclavian artery. So due to which there will be reduced blood flow to the upper limbs and absence or diminished pulses in the upper limbs, there will be decreased blood pressure in the upper limbs. Right? So in case of coarctation, there is increased blood pressure in the upper limbs. In Takayasu, there is decreased blood pressure in the upper limbs. So this is what is nothing but your reversed coarctation of aorta that is seen in patients with the Takayasu arteritis. Now, what is the criteria? Right? What is the criteria according to American College of Rheumatology for classification of the Takayasu arteritis? First of all, age at the disease onset is around 40 years. Right? So development of symptoms related to Takayasu arteritis is around 40 years of age. And claudication pain on examination, let me tell you, there will be development and worsening of fatigue and discomfort in muscles of one or more extremity while in use. So, while in use, there will be discomfort or pain or fatigue within the muscles of the upper limb. And whenever the individual takes rest, the pain reduces. Next, the third important is there will be decreased brachial artery pulse. Right? So, there will be decreased pulsations within the upper limb. And blood pressure difference between the two upper limbs should be more than 10 millimeters of mercury. Right? The blood pressure difference between the two upper limbs should be more than 10 millimeters of mercury between both right and as well as the left arm. And there is bruit, because what is happening to your subclavian artery? subclavian artery is getting narrowed, right? So there can be presence of bruit, right? There can be presence of bruit which is audible on auscultation. Right? There is bruit on auscultation, where either on one subclavian artery or on both the subclavian arteries you can have the bruit. And there will be abnormality within the arteriogram. So when you do an arteriogram, that will show you narrowing or occlusion of the entire aorta. Right? Narrowing or occlusion of the entire aorta. That is what the arteriogram abnormality will be. So there are totally 6 criteria now. Out of these 6 criteria, at least 3 of 6 criteria have to be present to diagnose the Takayasu arteritis. Right? Out of 6, there should be 3 criteria that should be present to diagnose the Takayasu arteritis. Okay. Now, having discussed this, you see another important question. Which of the following is the most common variant of Takayasu disease in India? Type 1, 2, 3 and as well as 4. So, in India, the most common type of Takayasu arteritis is type 3 is the most common form of Takayasu arteritis. Okay, let me discuss all these variants. You take type 1 Takayasu arteritis. There is involvement of arch of aorta and its branches. Right, there is involvement of arch of aorta and its branches. That is type 1 Takayasu. Whereas in type 2 Takayasu arteritis, there will be involvement of thoracoabdominal aorta and its branches. Right, there is involvement of thoracoabdominal aorta and its branches. Right, so that will be your type 2 Takayasu arteritis. Whereas type 3 is that you have combined features of right, you have combined features of type 1 and as well as type 2. So I'll just show you the image. If you observe, the arch of aorta and its branches, if it is involved, that will be your type 1 Takayasu arteritis. Whereas you take type 2 Takayasu. Type 2 Takayasu is that it is the involvement of thoracoabdominal aorta. Right, there will be involvement of the thoracoabdominal aorta and as well as its branches. Right, as well as its branches. So thoracoabdominal aorta is that like thoracic part of the aorta and as well as the abdominal part of the aorta. That will be your type 2 Takayasu. Type 3 is what? It is both. Type 1 and type 2 together. That means arch of aorta and its branches and thoracoabdominal aorta and its branches. That will be your type 3. Then what will be your type 4? See, in case of type 4 Takayasu, there will be pulmonary artery involvement. Right, there will be pulmonary artery involvement. Okay, so in case of type 4, you have type 3, right, you have type 3 and then pulmonary artery involvement. Whereas if you observe in type 5, there is involvement of coronary artery right, there is involvement of coronary artery and then type 3, right, and then type 3. So that will be your type 5 Takayasu arteritis, right. So, and out of which is most common in India? Most common in India is type 3 Takayasu arteritis. Now, having discussed this, what will be the investigations in these patients? Let me tell you, because it's an inflammatory component or inflammatory disease, the ESR will be increased. And what does this iotography shows? The iotography, it shows ostial narrowing of the blood vessels. Right, it will show ostial narrowing of the blood vessels, right, the one which is originating from the arch of aorta, right, the one which is originating from the arch of aorta. And investigation of choice will be MRI of the aorta. That will be the investigation of choice in patients with the Takayasu arteritis. Now, so this will be the MRI, right, wherein you can observe the narrowing at this point, right? Yes, so you can make out here where you have the narrowing. Okay, next, after having discussed about the investigations, so MRI findings, the diagnosis is established by imaging studies, usually MRI, which can detect the inflammatory thickening of the walls of the affected vessels, right? Or even you can do CT angiography, which can provide images of the stenosis, occlusion and dilatation, which is characteristics of your arteritis. Then, having discussed investigations, treatment, if you see, what is the drug of choice? Drug of choice will be corticosteroids. So, in most of the forms of the vasculitis, corticosteroids, they play a very important role, except for your Kawasaki. In Kawasaki, like what we give, the drug of choice is intravenous immunoglobulins. But here in case of Takayasu, right, the drug of choice will be corticosteroids. And this corticosteroids, the example is prednisolone. Right, the example is prednisolone. So this prednisolone, it should be given at a dosage of 1 milligram per kg, and this has to be given for nearly around 1 month. Right, this has to be given for nearly around 1 month. So this prednisolone should be given at a dosage of 1 milligram per kg for nearly around 1 month. And this has to be followed by taper over several months to 10 milligrams daily. So you have to taper it to 10 milligrams daily. So this will be the mainstay of treatment in the treatment of the Takayasu arteritis. Right. Now, for suppose if the individual is refractory to glucocorticoids, then what are the drugs that has to be added? So the addition of methotrexate, azathioprine or mycophenolate mofetil to prednisolone may be more effective than prednisolone alone. So to this prednisolone, you have to add methotrexate or azathioprine or mycophenolate mofetil. Okay, so either of these drugs to be added to the prednisolone, they may be more effective, right? Now, apart from these immunosuppressants, even the biologicals. So if you take the biologicals, that includes the inhibitors of the TNF, right? Inhibitors of the TNF. And these inhibitors of the TNF, examples, what we have is infliximab, right? Inhibitors of the TNF, that includes the infliximab or the interleukin 6 receptor inhibitors. Right, interleukin 6 receptor inhibitors, they include tocilizumab, right? That includes tocilizumab. They may be effective for patients who are refractory to prednisolone, right? And this particular Takayasu arteritis, it has a chronic relapsing and remitting course that requires ongoing monitoring, and adjustment of the therapy is very much required. So this is about the treatment of Takayasu. So let me just summarize this particular Takayasu arteritis. Takayasu arteritis is a large vessel vasculitis, and you should note the type of inflammation in Takayasu arteritis. It is granulomatous inflammation. Right, it is the granulomatous inflammation. Then followed by that, the difference between Takayasu and giant cell is that mainly age group. Giant cell arteritis more than 50 years. Takayasu arteritis, the age of onset is 40 years. And the main vessel which is affected in Takayasu is subclavian artery, which is originating from aorta. That is the reason why it is called aorta arteritis. And another name of it is pulseless disease. And because of the involvement of subclavian artery, there can be difference in the blood pressure between the right and as well as the left upper limbs. And there are many other conditions where you have difference in the blood pressure between right and as well as left upper limb. That is pre-ductal coarctation of aorta, right? And as well as the aortic stenosis, right? And that too supravalvular aortic stenosis, okay? And followed by that, because of the involvement of subclavian artery, the individual will have claudication pain within the upper limbs, and there can be even Raynaud's phenomenon as well. And because of the involvement of common carotid artery, there will be visual changes, transient ischemic attack, syncopal attack, and there will be ischemic stroke as well. And because of the involvement of the vertebral artery, the individual will have the development of dizziness. And because of the involvement of the abdominal aorta, the individual will have abdominal pain, nausea, and as well as vomiting. And because of the involvement of the celiac artery, there will be decreased blood supply to your foregut. And because of the involvement of the iliac arteries, the blood supply to the lower limbs will be reduced, and there will be claudication pain within the lower limbs. And because of the involvement of the renal artery, there will be development of renovascular hypertension. And if it is unilateral renal artery stenosis, you can give ACE inhibitors or ARBs. But if it is like bilateral renal artery stenosis, you need to do percutaneous transluminal renal angioplasty, right? You need to do a stenting of that particular bilateral renal arteries, okay? Right. Now, after having discussed about the clinical manifestations, you need to know that the Takayasu arteritis, we can compare it as reversed coarctation of aorta. And we have totally 5 types of Takayasu, out of which type 3 is the one which is more common in India. Type 1, it is involvement of arch of aorta and its branches. Type 2, it is thoracoabdominal aorta and its branches being affected. Type 3 is both. Type 1 and type 2, if you combine, it will be type 3. Type 4, it is pulmonary artery involvement plus type 3. And type 5, coronary artery involvement plus type 3. And investigations, ESR will be elevated. When you do an iotography, there will be narrowing of the ostial component of the vessels which are originating from the aorta, and investigation of choice will be the MRI of the aorta. Drug of choice will be prednisolone, and in those individuals who are refractory to prednisolone, we need to give the methotrexate or azathioprine or mycophenolate mofetil. And the other drugs are like biologicals we have, that is inhibitors of TNF, that is infliximab, and interleukin 6 receptor inhibitors, that is tocilizumab. So this will be about your Takayasu arteritis. Thank you very much.